Usually when we think about the human body reacting to damage, we picture a slow building process, like a bruise forming or a fever steadily rising. But when dealing with an ingested toxin, your body doesn't do slow. It has a hardwired, highly aggressive biological eject button. Today, we're doing a deep dive into a clinical pharmacy lecture to decode exactly how a specific drug class, the 5HT3 receptor antagonists, actually hacks that fail-safe.
And that eject button is, it's incredibly sensitive. Like the second noxious stimuli, whether that's chemotherapy, radiation, or even just spoiled food damage, the enterochromaffin cells lining your gut, those cells react instantly. They release a massive, violent dump of serotonin.
Which is wild because, we normally think of serotonin as the brain's happy chemical.
Right, exactly.
But the vast majority of the body's serotonin is naturally stored right there in the gut. So that sudden release is basically a systemic fire alarm, right? It just cranks up gut motility to orchestrate a rapid system-wide purge.
Yeah, it's definitely not about mood here. That serotonin dump floods the 5HT3 receptors on your vagus nerve.
So the vagus nerve is like the hardwired alarm wire.
You got it. And that wire shoots a 911 signal straight up to the chemoreceptor trigger zone, the CTZ. I like to think of the CTZ as the brain's chemical sampling station. It sits right outside the blood-brain barrier, constantly tasting the blood for toxins. And once it gets that signal from the vagus nerve,
the bodily sprinkler system goes off, the whole vomiting sequence is initiated.
Exactly.
Okay, so if the vagus nerve is the wire sending the distress signal and the CTZ is the receiver, we basically need a chemical way to sever that connection before the brain gets the message.
Precisely. And we do that by capping those receptors with 5HT3 antagonists. These are the drugs ending in citron. You use them during the acute phase, so that critical first 24 hours after a toxic event.
You have to block the binding sites before the alarm starts blaring.
Yes. But what's fascinating, like you look at the clinical literature, is just how differently these antagonists perform at a mechanical level. Palonosetron is the undisputed gold standard here.
Oh, the clinical data on Palonosetron is just wild. It boasts a 40-hour half-life.
Which absolutely crushes the 4 to 9 hours of its competitors.
Right. But it's not just sticking around longer in the plasma. The lecture describes it as having a pseudo-irreversible grip. So while other drugs in this class might just block the door for a few hours, Palonosetron basically changes the locks. It keeps the alarm muted even after the bulk of the drug leaves the bloodstream.
Yeah, it binds with such extraordinarily high affinity that it actually triggers receptor internalization.
Wait, really? The cell pulls the receptor inside itself?
Yeah, exactly. It renders it completely inaccessible to the serotonin. But then you contrast that incredibly sophisticated mechanism with the absolute opposite end of the spectrum, Dolasetron.
Or worst in the class.
It has the lowest demonstrated efficacy for preventing vomiting, yes.
Okay, hold on. Let's unpack this for a second. Because if Dolasetron is that ineffective, and according to the safety data, it carries a severe risk of QT prolongation.
Which delays the heart's electrical recharging system, yeah.
Exactly, which can literally cause fatal, chaotic arrhythmias. How does a drug like that stay on the market? Why is any pharmacy still stocking it?
Well, it highlights a major structural flaw in how medical guidelines are often developed. Broad guidelines frequently blanket approve an entire drug class simply because they share the same baseline mechanism.
Just because they all technically block 5HT3.
Right. It takes years of meta-analyses and real-world clinical data to actually tease out the massive disparities in efficacy and cardiac safety between individual agents inside that umbrella.
Which completely changes the conversation you should be having with your doctor before a major surgery or, if you're managing a severe case of morning sickness.
Absolutely.
Knowing that Palonosetron mechanically alters the receptor to hold the line longer and safer gives you a vital voice in your own care. You don't have to just blindly accept whichever drug they happen to pull from the approved class.
It underscores why understanding the underlying pharmacology actually matters. You aren't just taking a pill. You are strategically intercepting a biological cascade.
Speaking of that cascade, there's a paradox in the source material regarding serotonin syndrome that is, it's still stuck in my head.
Oh, yeah. That's a highly debated one.
Right, because if we forcefully capped those 5HT3 receptors, that massive serotonin dump in the gut doesn't just vanish, it gets shunted into alternative receptor pathways, right? Like 5HT1 or 5HT4, just flooding them instead.
And overloading those alternative pathways can trigger a dangerous systemic overdrive. We're talking symptoms like rapid heart rate, severe tremors, hyperthermia. It's a terrifying mechanical consequence of blocking one door and forcing all that chemical energy through the windows.
It really makes you wonder, if we are forcing all that chaotic chemical energy down different biological hallways, what other unseen domino effects are we triggering every single time we try to artificially silence a single alarm system in the human body?